Can you see my screen?
Yeah.
I can see us.
Okay, so now it's 8:01. We can wait for probably 2-3 minutes.
Sure.
Let's now keep joining. We have now over 20 participants, so yeah, we can wait for two, three
Yeah,
minutes
let's wait on.
more, and then
Yeah,
we can start.
sounds good.
One minute more.
Hopefully we get more, huh?
Okay. Okay, we can start. Good evening, everyone, and welcome to the third session of Regenerative Edge EmCyte webinar series. I'm truly excited to have you with us today as we continue exploring the frontier of regenerative biologics in medicine. Tonight's focus is particularly timely and important: platelet-rich plasma therapy in reproductive medicine, a field that is evolving rapidly with both exciting clinical progress and unanswered questions that we will explore together tonight. This session is a live question answer format, and we will be diving into the mechanism of the PRP tissue regeneration, clinical application in conditions like poor ovarian reserve, thin endometrium, and implantation failure, as well as the real-world challenges of standardization, protocol optimization, and biologic uh, variabilities. I'm honored to be joined tonight by two distinguished key leaders in the field of reproductive medicine: Dr. Michael Alon, a double board certified physician in reproductive endocrinology and infertility and OBGYN. He also served as president of Advanced Fertility Center of Texas and brings extensive clinical experience with PRP in fertility care. His insights into patient-centered application and biological optimization are incredibly valuable for tonight's discussion. Also with us is Dr. Beata Turalik, a board-certified OBGYN in Poland and PhD in OBGYN science. She currently serves as research director and head of IVF department at Advanced Fertility Center of Texas, and offers a powerful translational perspective at the intersection of science and reproductive care. And I am Sina Farzaneh, PhD in regenerative medicine, tissue engineering, and regenerative medicine, with focus on translational regenerative medicine. I'm serving as a scientific director of EmCyte Corporation. I'll be guiding tonight's session and contributing from both the research and product development side, particularly where science meets clinical application in biologics like PRP. Before we begin the main content, I would like to give our guest speakers a moment to say hello and greet the audience. Dr. Allen, would you like to start with quick greeting?
Hello, I'm Dr. Michael Alone. I'm here in my office at Advanced Fertility Center of Texas in Houston.
Hello, Beata Tralik. I am actually on vacation in New York City, but it's my great pleasure to be with everyone tonight.
Great. Thank you both for being here and for sharing your time and expertise with us. So to get us started, I will begin with around 15 minutes introduction to lay the groundwork. Then we will move to Dr. Beata Tralik for 20 minutes presentation, followed by Dr. Michael Alone, who will present for another 20 minutes. After all the talks, we will open it up for a question and answer session. Feel free to submit your question anytime through the chat. I will be collecting them and we will address them at the end of the session. So with that, let's get started. Okay, so reproduction is a fundamental biological function that sustain the survival rate of our species, but it's also deeply intertwined with identity, emotional well-being, and family structure. For many couples, the ability to conceive and carry a pregnancy is a critical life goal, and infertility can carry profound emotional and social consequences, especially in cultures where parenthood is deeply valued. So globally, infertility affects about 1 in 6 couples, with both male and female factors contributing. Over the past 2 decades, infertility rates have steadily increased due to environmental, lifestyle, and medical factors. Despite advances in fertility treatment, success rate remains suboptimal, especially for women with endometrial or ovarian issues. So we have some well-known causes of the infertility. For female infertility can result from ovulatory disorders, tubal damage, uterine abnormalities, and poor endometrial receptivity. In addition, premature ovarian insufficiency and recurrent implantation failure are major challenges in IVF clinics. Importantly, many of these conditions involves tissue damages or dysfunctions, making them ideal targets for regenerative medicine. In addition to female factors, male infertility is also an important cause. The main issue is often low semen quality, which can include low sperm count, poor motility, abnormal sperm morphology, and no sperm at all. Other contributing factors include testicular malformations, hormonal imbalances, varicose cells, and blockage in the male reproductive ducts could be another issues and another cause for infertility in males. These issues can impair the ability of sperm to fertilize the egg and must be considered during infertility evaluation. Traditional treatment like IVF, hormonal stimulation, and surgical repair have made great strides, but many patients fail to respond, especially in case of thin endometrium, poor ovarian reserve, or recurrent implantation failure. These are the cases where we urgently need to have a new tools and where regenerative approaches are now offering real hope. Regenerative medicine aims to restore structure and function to damaged tissues using the body's own healing mechanism. It includes technologies like stem cells therapy, platelet-rich plasma, and tissue engineering. In reproductive medicine, Regenerative means revitalizing the endometrium, reactivating ovarian function, and improving the uterine environment for implantation. Several regenerative options are under studies. Stem cells from bone marrow or menstrual blood, PRP, platelet-rich fibrin, and even exosome. Regarding to stem cell therapy, stem cells have been trialed in conditions like Asherman syndrome, thin endometrium, and ovarian insufficiency with some promising outcome. However, stem cell therapy is still experimental, costly, and tightly regulated to the safety and ethical concern. This limits its use in routine fertility care for now. And so far, based on the most updated result in the website clinicaltrial.gov, so far we have a total of 67 global clinical trials using a stem cell therapy for female infertility. And most of the registered clinical trial on stem cell therapy for female infertility are in the early phases and primarily initiated by academic institution. There are different countries involving in these trials, but China leads in the number of the trials and driven by supportive policies and a large patient populations. And the important things regarding to the main portion of these clinical trials using the stem cells is most of them, they are using prenatal tissue-derived stem cells, particularly umbilical cord mesenchymal stem cells, which is mostly allogenic source. And at least in the United States, we have regulatory issues using allogenic sources for stem cell therapy so far. So unlike the stem cells, PRP, which is autologous, low risk, and easy to prepare in a clinical setting, can deliver a cocktail of the growth factors and cytokines directly to the target tissues. PRP has already been used in over 20 different medical specialties and is now gaining traction in reproductive medicine for its ability to regenerate the endometrium and ovary for ideal cases, not for every cases. It cannot do miracle, but for ideal cases, it works perfectly in combination with other modality. As you can see in the cartoon, based on the result of a systematic review recently published, they in that systematic review they analyzed 49 studies, including both human studies and preclinical studies between 2020 to 2024, mostly for the study for PRP therapy in case of diminished ovarian reserve. And they checked the pregnancy outcome after PRP therapy, and the results are optimistic and the results are promising. So biochemical pregnancy rate increased 18%, spontaneous pregnancy rate increased 7%, live birth rate is around 11%. And also, when you search through the literature and check different publication and report, you can find the different results, and results are vary between 10% to even more than 20%, 25% success rate for PRP therapy. But why we have so many differences regarding to the results? Although PRP therapy has shown promising results in reproductive medicine, outcomes vary widely between studies and patients. Some show significant improvements in endometrial thickness or ovarian function, while others report minimal or no responses. This inconsistency is not surprising, and it highlights that PRP is not a one-size-fits-all therapy. The differences arise from multiple variables across protocol, patient, and preparation technique, and we are going to talk about them. The first different factor contributing to the PRP outcome we need to consider before using PRP in reproductive medicine, and even in all other fields when we practice, we must first ask ourselves, what is our biological goal? PRP can act either as regenerative biologic or an anti-inflammatory biologic. Dominantly, they can be interchanged, but dominantly it could have one of these distinct rules. Depending on its cellular composition, especially the type and the concentration of the platelet, leukocyte, and cytokine, PRP will lean toward one of these profiles. So for each indication, we must decide, do we want to minimize the inflammation, or do we want to create a controlled inflammatory response to initiate the regeneration? Without that clarity, PRP becomes a shot in the dark. For example, recently there is a study published, and they brought an idea which focused on dynamic beneficial role of mononuclear cells, specifically classical monocyte and monocyte-derived macrophage, in endometrial repair and scarless healing. You choose of platelet-rich plasma formulation should reflect the goal of enhancing tissue regeneration and modulating the inflammation, rather than simply reducing inflammation broadly. So, in this case, maybe if we want to choose between the different formulation of the PRP, we prefer PRP with high concentration of the platelet alongside with high concentration of the monocyte. So I would, from the basic science view, I would suggest monocyte-rich PRP, not leukocyte-poor or leukocyte-rich PRP. Another example could be based on another study, and they found that, and they brought another idea regarding to ovarian insufficiency, premature ovarian insufficiency, and they in this study they brought that idea as chronic inflammation for ovarian tissue as inflamed aging. So in this case, we have a kind of persistent chronic inflammation. So if we treat that case with leukocyte-rich PRP, maybe it's going to be a kind of putting the gas on a fire. Maybe we need to optimize our formulation to just target the inflammation in this case. So in this case, based on the basic science view, I would suggest leukocyte-poor PRP with high concentration of the platelet, low concentration, and minimizing the neutrophil and also other leukocyte components like monocyte and lymphocyte. You can see, based on different indication, we need to decide which formulation could be the best for that specific indication. Another thing we need to consider is need for PRP characterization and dosing. Once the goal is defined, we need to characterize the PRP formulation. Most studies don't even report the number of the deliverable platelet, and when they do, the number vary dramatically. We cannot rely on concentration factor, which is very common in the reports, because it's gonna be manipulatable easily by changing the volume. We need actual number of the platelet, deliverable platelet, for each tissue, for each site of injection, and for each indication. Even the volume, we don't know the exact volume in most of the cases in the literature, and sometimes we don't have that that consensus about the volume, because it's not just the platelet. Even on the volume of the PPP, we have different proteins can influence on the outcome. So we need to first determine the dosing, the deliverable dose of the platelet, and then the volume of the injection for each indication. Look at this chart, which is very simple. So in everybody, we have a range of the platelet in our blood baseline. It can be vary based on person to person. It could be between 150 to 450 in the baseline. Now here we have 3 times difference. So you can see if we don't characterize our platelet, our PRP regarding the platelet number, the outcome could be 3 times different based on the number of the platelets. So it is necessary for us, and it's the need to reconsider that, to determine, to characterize the PRP regarding to the dosing and number of the platelets. Another factor we need to determine is the need for PRP cellular characterization. But PRP is not just about the platelet. Monocyte, lymphocyte, neutrophil are active biologic players in the PRP alongside with the platelet. Their balance influences whether PRP promotes regeneration or suppress the inflammation. And we know during the PRP preparation, we have, based on the mechanism of the PRP preparation using centrifugation, we have different layer of the cellular component in our buffer coat. And it's very close to each other, and even sometimes they merge, these layers merge to each other. So we need to characterize regarding to other cellular component to make sure our formula is fit for our indication and for our goal. Based on this idea and mindset, with our commercial kit in the EmCyte, we introducing different formulation for different indication, and our system obviously gives us this opportunity and flexibility to have different formulation based on the different concentration of leukocyte and other cellular component alongside with the PRP. So another thing we need to ask ourselves is preparation method. So we have bunch of different preparation method in the literature and the protocol, society, different fields of the regenerative medicine, and which one is best for us and fits for our practice. We can have single spin, mostly it's not PRP because our concentration factor is going to be only 2 times, and it's not clinical PRP. And if we want to have the clinical PRP with high amount of the platelet, we need to have double spin. So we have different techniques for preparing the PRP. Also, during the preparation, we need to consider what types of anticoagulant we are using. Some anticoagulant also, although they help to inhibit the coagulation cascade, but they can affect the quality of the PRP regarding to some specific purpose. For example, if we need angiogenesis, we recommend using citrate instead of ACDA, since based on lots of evidence and solid evidence, we know ACDA can affect on angiogenesis and endothelial cells. So you can see some tiny factors, some simple factors can affect on the outcome of the PRP quality, and the effect could be big. Also, activation or non-activation, we don't know. There is no consensus, specifically in the field of reproductive medicine, regarding to activation or non-activation of the PRP for reproductive medicine. We need to consider this as well. Some other factors we need to consider, like patient health history and some background of the patient, diet, supplements, medication, because they also can influence and sometimes affect their quality of the platelet in our PRP. So regarding to preparation, so most of you are familiar with EmCyte kit and EmCyte system. After drawing blood, we have the system for double spin mostly. We can spin the blood for the first spin. After first spin, we have two distinct layer platelet suspended plasma and also red blood cells, and between them we have the buffy coat, which is the layer of the platelet, monocyte, lymphocyte, and neutrophil. And after first spin, we carefully remove the yellow portion, which is the platelet suspended plasma with the buffy coat, and transfer it in the another compartment of our kit, bottom chamber of our kit. And then after second spin, we have the buffy coat at the bottom of the kit, bottom of the tube, and we can resuspend the buffy coat with the desirable amount of PPP based on our final volume to make the PRP. So our current system is double spin with high recovery rate of the platelet. And also, as I mentioned before, with our system, we can provide that opportunity to have and flexibility to have different formulation for the PRP. If we need for our practice leukocyte poor, we could have high recovery and capture rate of the platelet over 90%, around 90%, and even over 90% without getting any red blood cells and without any contamination of the neutrophil and minimizing other leukocytes. If we want to have the benefit of the monocyte, we can have the monocyte-rich PRP with getting half cc of the red blood cells after taking the whole buffy coat. And if we want to add the neutrophil and get beneficial of the neutrophil regarding to some purpose like angiogenesis, we could have 1 ml red blood cells after getting the buffy coat. So you can see this commercial kit gives us the flexibility for different formulation preparation. And in all of the cases, our recovery rate for platelet is over 90%. So the last slide I'm going to talk about and pass the podium to Dr. Tralik is future perspective regarding to regenerative approach in reproductive medicine, specifically PRP therapy and other modalities. So now one of the hot topics regarding to the PRP is PRP can activate the AMPK SIRT1 signaling pathway when we inject through the ovary. And it can be a kind of ovary mitochondrial biogenesis signaling pathway. And so still it's very, very preliminary and at initial step of the research, but it could be a kind of good idea regarding to PRP therapy for a specific mechanism for a specific purpose. I know now the longevity field and also kind of senescence field, anti-senescence field is very hot regarding to mitochondrial biogenesis, and it's going to be a kind of interesting field for those researchers as well. Recently, a couple of the publications pops up regarding to intratesticular PRP injection, and so far the results are very promising regarding to motility of the sperms and even fertility of the sperms. Also, the idea regarding using the PRP as freezing media or a supplement for freezing media for cryopreservation of the egg and sperm has been emerged, and a couple of the university centers and institutes started using this technique. Results are not solid enough, but very, very promising. And also the idea regarding to telomerase reactivation strategy using c-MYC and KLF4, this types of idea comes from the Yamanaka factor and iPSC development to stop the telomerase breakdown to a kind of decelerate or inhibit the senescence of the cells, specifically in this case for egg or sperm. And also another hot topic now in this field is oocyte generation using iPS technique. Now all of the research is at the preclinical level, in vitro and preclinical level. We are so far from the human trial because there are lots of concern regarding to iPSC, but the idea is very promising and can be very motivating. So thank you for your time. Now I can pass the mic to Dr. Tralik. Do you want Dr. Tralik bring up your slide by myself?
Yes, please. I will prefer if you control my slides.
Oh.
I will feel more comfortable. It never works on me when I start sharing the screen.
Okay, everybody can
good-
see Dr. Tralik's.
Good evening, everyone. Again, Beata Tralik. I work for Advanced Fertility Center of Texas, and I am the one who brought the idea of PRP treatment to our clinic. And it's my great pleasure and privilege to share with you, with everyone, our experience we have so far with this very interesting treatment. How did it start? It all started back in 2018 from one very difficult patient. It was a relatively young patient who had good quality frozen embryos. And to our big surprise, when we started preparing her for frozen embryo transfer, patient had very, very thin lining, around maybe 4 millimeters, no more. We tried multiple treatments. We came up with multiple protocols, change route of medication administration, multiple supplements, prayers, whatever we thought about, nothing worked. And by doing some research, we came across platelets PRP therapy as possible option for this patient. So we had great idea, but we had no idea actually how to start and how to separate platelets. But fortunately for us, EmCyte came to the rescue. We had EmCyte in Houston. We did contact great specialists. They helped us to establish a protocol for this patient. We Dr. Alon flushed the uterine cavity twice with the PRP. How did it go? Not well, I will be honest, didn't work for this patient. And because it was like ad hoc one-time treatment, we kind of kept going with our life until the end of 2019, and we came back to this topic, but this time we tried to establish some type of treatment for bigger group of patients, to establish some type of criteria, protocols, etc. And while thinking about this, we had two patients related to each other, twin sisters, very knowledgeable, who Dr. Alon qualified for donor eggs use. And those two patients didn't accept this option. They declined, which happens very, very often. They wanted to try every possible option to use their own eggs. And they heard about the clinic actually in Chicago that offers PRP. But somehow they found out that we plan to do it. We were not ready yet, not at all, but those 2 patients qualified themselves for the procedure in our clinic. So we had no choice and we did it. How did it go? Not well. And then COVID came, so everything kind of fell apart. We got discouraged. But then COVID passed, life came back to normal. We said, no, we cannot give up so quickly. We have to keep trying. And our next patient was patient in mid-30s. And actually, Dr. Alon will go over this case in more details. But it was patient in mid-30s with diminished ovarian reserve, failed IVF meaning that she had no frozen embryos. We did PRP, ovarian rejuvenation with PRP on this patient. And to our big surprise and then big happiness, patient got pregnant on her own. So, and this is how it really started. Now, to my knowledge, this webinar is not only for medical professionals. Possibly we have also patients here interested in this type of treatment. So maybe a few words kind of to remind or to explain what actually platelets are. So the platelets are cellular components found in blood that play critical role in the clotting system, and they prevent excessive hemorrhage after injuries. The platelets originate from megakaryocytes, and on the surface, they have molecules that facilitate response to platelets, response of platelets to the injury. Next slide, please. Next slide, please. Now, but what is more interested for us is what is in the cytoplasm of the platelets. We have 2 types of granules, dense and alpha granules. Alpha granules are the most abundant, and they are rich in multiple cytokines and growth factors. I never remember all of them. This is why I have some of them listed here. Next slide, please. And those cytokines and platelets-derived growth factors located in alpha granules play vital roles in many biological processes like cell proliferation, differentiation, angiogenesis, and regulation of apoptosis. And those attributes underscore potential application in assisted reproduction, where they are believed to contribute to tissue repair, wound healing, and blood vessel regeneration. Next slide, please. Now, regenerative therapy in general uses our own body self-repair mechanisms. Now, PRP therapy facilitates organ regeneration through few mechanisms: by exerting anti-inflammatory effects, by orchestrating extracellular matrix remodeling through synthesis of collagen and fibronectin, promoting angiogenesis. Now, the role of VEGF-induced angiogenesis is well documented in normal ovarian function and during the endometrial thickening. So logically, downregulation of VEGF is associated with decreased angiogenesis, leading to reduced development of antral follicles and affects growth of lining in patients. VEGF, by stimulating formation of new small capillaries, improves delivery of oxygen and nutrients to cells. Also, platelets direct cellular recruitment, including mesenchymal stem cells, to the site where they're injected to, promoting differentiation and reparative processes. Next slide, please. Now, what are main indications of PRP use in reproductive medicine? Is poor ovarian response, primary ovarian insufficiency, poor quality or no frozen embryos in previous IVF cycle, thin lining, recurrent implantation failure, Asherman syndrome, and chronic endometritis. Next slide, please. Now, a few words about PRP use in ovarian rejuvenation. PRP has been introduced as the part of ovarian rejuvenation, to improve response to ovarian stimulation in patients with poor prognosis. Now, we characterize poor prognosis by factors such as advanced female age, diminished ovarian reserve, underlying female infertility, and response to medications. Next slide, please. Now, there were few both non-randomized and randomized studies published on PRP use for ovarian rejuvenation. I will go over a few, and I will try to do it fast, and I will do my best not to be boring. And I will also kind of explain how it looks like from our perspective. For example, here in 2018, Seals published his research on 4 patients diagnosed with diminished ovarian reserve. All those patients were treated with a PRP. And next slide, please. And then Patrick in 2020, very similar, also bigger, a little bit higher amount of patients, 38 patients diagnosed with diminished ovarian reserve, all of them treated with PRP. And what is the conclusion of those 2 studies? According to those authors, the ovarian reserve, AMH, goes up after PRP treatment. Now, for those who are not in medical field, AMH is hormone that shows us if patient has good ovarian reserve, increased or decreased. The lower AMH, the lower ovarian reserve, meaning the less eggs patient has left in her ovaries. Now, I would say that our observation is a little bit different. We have checked AMH multiple times after PRP treatment, and we have not noticed improved ovarian reserve. Although what we have noticed, improved response to medication. So after PRP use, very often we see higher amount of retrieved eggs. Doesn't mean the patient has higher ovarian reserve. It means only that patient responded to stimulation way better. So we were able to retrieve better amount of the eggs, very often better quality, which actually results in higher amount of good quality frozen embryos. Next slide, please. This is the study published in 2022 on 12 patients who underwent IVF treatment and had aneuploid embryos. Aneuploid embryos mean that the embryos were tested genetically and they were not, let's say it's not normal, they were affected genetically. And after PRP treatment, the amount of normal euploid embryos went up from 8% to up almost 40%. So in this and 3 clinical pregnancies were achieved. So those authors suggest that the PRP can increase the chance that the patients will have genetically normal embryos, which we also would argue a little bit, because I want to circle back to better response to medication. Whenever we have higher amount of retrieved eggs and higher amount of frozen embryos, we have better chance to find euploid embryos. Although we had a quite good amount of the patients, especially around 40, a little bit over 40 years old, who had IVF treatment somewhere else in different facilities, and they had no frozen embryos. All embryos were arrested. So they came to us, and after PRP treatment, we were able to freeze very often even good quality embryos, good quality blastocysts. Also, in many of those cases, embryos, especially when we are talking about patients who are 40s or over 40, the embryos were genetically affected. Next slide, please. There have also been published studies with negative results regarding the efficacy of PRP in ovarian rejuvenation. Next slide, please. For example, 2 of them, one published in 2019, one published in 2022. Here, authors don't see any benefits of PRP use in ovarian rejuvenation. Although Stojkowska noticed trend towards higher implantation and live birth rates among patients who received PRP prior to IVF. Next slide, please. Now here, this is the another study published in 2022 on patients with 80 patients with extremely low functional ovarian reserve, aged 28 to 54. And then again, authors didn't see any benefits of PRP use. However, 2 patients with a very poor prognosis, aged 40, who had previously failed IVF cycles at other centers, achieved pregnancy after PRP treatment. Now, our comment about this research, first of all, patients with extremely low ovarian reserve are very, very difficult group of patients. And if we add patient who is 54, then I would say there is nothing to rejuvenate at this point. So here in this study, I would really question the age group that was selected for this research. At one point, we should stop trying to rejuvenate ovaries. Next slide, please. There were also 2 randomized trials published in 2024. In those randomized trials, authors also have not noticed any benefits of PRP use in ovarian rejuvenation. Next slide, please. And now, even though those 2 randomized trials didn't prove that PRP can improve fertility, this field is still exploratory. And after those earlier non-randomized studies and case series suggested potential benefits, which led to initial enthusiasm. And we at AFCT, we are still very, very enthusiastic, but we all know that this study, this field needs further research on a bigger group of patients with better standardization and optimization of the treatment, what Dr. Farzan highlighted multiple times today. Next slide, please. PRP has been also used multiple times in the patients with thin lining. The increase in endometrial thickness plays very important role in both implantation and in pregnancy. And then endometrial thickness at least 7 millimeters is considered ideal for embryo transfer. Next slide, please. Now, they have been both non-randomized again and randomized studies on PRP use for thin lining. Most studies actually addressing the PRP use on thin lining found positive, good results. For example, here, Chang, 2015, the study on 5 patients between 31, 39 years old. All those patients had thin lining, received treatment with the PRP. In all those patients, lining grew to over 7 millimeters, and all those patients actually got pregnant. Next slide, please. Another research in 2017, here patients with lining 5 millimeters prior to PRP treatment. After PRP, lining grew to over 7 millimeters, and positive pregnancy test was achieved in almost 61%, and clinical pregnancy rate was in 45% of patients. Next slide, please. Now, there have been also randomized trials on PRP use in thin lining, here published in 2018 on 83 patients. And also here, authors have noticed very positive effects, beneficial effects of PRP use in thin lining, in patients with thin lining. Next slide, please. Again, 2019, 60 patients. It was double-blind randomized trial, and again, authors have noted very positive effect of PRP use in patients with a thin lining. Next slide, please. In summary, most of studies on the use of PRP to treat thin lining in patients undergoing IVF treatment suggest that this treatment may improve implantation rate. Although in the most recent studies, the authors kind of question the benefits of PRP, which boils down to whatever we already discussed, that this field needs further research on the bigger group of patients with better standardization of optimization, how our own observation looks like in the patients with thin lining. I will be very honest with everyone, we really don't struggle with patients with thin lining for whatever reason. I don't know if we are so good or maybe we are so lucky, I don't know. But yes, the first case that I mentioned in 2018, that unfortunately we were not able to help this patient. The second patient which we had with really thin, truly thin lining, it was the patient, we had her in 2023, 39 years old, poor responder. So it was very difficult to stimulate this patient. Finally, we were able somehow kick her over with the medications. We ended up with one euploid pretty boy frozen because the patient was almost 40 years old. We discussed, Dr. Alon discussed with her repeating another IVF round to accumulate more embryos to protect her fertility, her future. Although for the whole treatment, the very tough stimulation was so difficult emotionally and physically and financially for this patient that she decided to move forward with frozen embryo transfer, and to our big surprise, the patient had thin lining. So it was very, very stressful for us because we had only this one tiny boy frozen and thin lining. So again, we went through multiple protocols, changed route of administration of medications, supplements, whatever we could think of, nothing helped. So we moved forward with the PRP, which actually helped. The lining grew to over 7 millimeters. Patient got pregnant and delivered healthy boy. So like I said, and then there was one more patient. Yes, this was not our patient. This patient was referred to us due to thin lining from the clinic in Austin. The lining grew after PRP, after the uterine cavity was flushed with PRP twice. But we did follow up with this patient after the treatment in Austin was completed. Patient got pregnant, but unfortunately had a miscarriage. So like I said, we don't struggle much with thin lining, but what we struggle with, and next slide, please, is recurrent implantation failure. And this is very frustrating topic. It's unsolved problem in assisted reproduction that has led to plateau of our successful rate. It's very, like I said, it's very frustrating for us and it's very frustrating for patients. If we have patients young with good lining, good quality embryos, genetically tested normal, it's sometimes very difficult to understand why a patient is not getting pregnant. Moreover, sometimes those are patients who years earlier got pregnant on their own, and now we struggle. This is very, very complex problem that can arise from different etiologies like advanced age, smoking, body mass index, stress, immunological factors, infection, and uterine pathologies. Next slide, please. There were quite a few non-randomized and randomized studies on PRP use for recurrent implantation failure. Here I listed few of them, two published in 2019, one published in 2022. Next slide, please. And in most retrospective studies, the authors see lots of benefits of PRP used in patients with recurrent implantation failure. Next slide, please. But there are some other studies during the same period showing contradictory results. Like Dr. Farzaneh mentioned at the very beginning, it's not big surprise because again, and we will be repeating this multiple times, we definitely need further research on bigger group of patients with better optimized and standardized protocols. Also in our clinic, we definitely see big advantage of PRP use in recurrent implantation failure. I would say that the successful rate in this group of patients went up to around 60%. The next slide, please. I am almost done. I am just showing this picture to kind of remind everyone what is our goal. This is our goal. Happy faces of both mom and her baby. So whatever we do, whatever we think of in our clinic, this is our main goal. We want everyone to leave our clinic pregnant and 9 months later to come back with a baby. So we are very, like I said, we are extremely passionate about the PRP use. We are extremely lucky and happy that we came across with EmCyte and EmCyte's great specialists. But yes, like I said, we are very, very passionate, but at the same time, we set up very realistic expectations with our patients. Whenever Dr. Alon talks to patients, he really qualifies them carefully. And sometimes we have to say no to our patients. Not everywhere we don't believe that the PRP is some type of magic treatment that will work for everyone. And unfortunately, this is what patients sometimes think. They will come, they will do PRP, and the PRP that will do its magic. No, it doesn't. And we even have some arguments with patients who are telling us, you have to do it because I will pay you. No. It's not about the payment. It's about us believing that whatever we do will work. And whenever we don't believe that the benefits will outweigh the risks, unfortunately, we'll have to refuse. Thank you so much. And Dr. Alon, screen is yours.
Thank you. Thank you, everybody. Being the last speaker is the most difficult part because then I'm trying not to bore you and keep your attention intact. Of course, I'm going to review a few of the things that both Dr. Terlik and Farza reviewed to kind of help you put it all together, hopefully.
Sorry for interruption, Dr. Alon. Would you please share your screen?
You cannot see me, or?
We don't see your presentation.
Oh, can you put it on for me?
Okay, let me try.
Perfect. Perfect. So basically, as you know, I'm the medical director and physician here at Advanced Fertility Center of Texas, and the reality is we're always trying to bring the latest and most advanced therapy to our center to kind of help our patient do something a little different than regular conventional IVF or conventional intrauterine insemination, try to help them reach their goal faster without the heartache. Next slide.
Sorry, I don't have a control on it. Just a second.
Dr. Farzanek, this is the stress that we both wanted to avoid, giving you the control over our presentation.
Yeah, I don't know for what reason I don't have the control. Maybe you have a control, Dr. Alon?
I don't have the presentation. I wonder, maybe I could perhaps do it here. Can you see me now?
Dr. Alon, do you have your presentation on your laptop right now so you can share the screen?
Maybe I don't know how to share the screen now.
On the bottom panel, you have like this green arrow share.
Okay, let me.
Do you see it?
Yeah. I don't think I can know how to share it. No, you cannot turn the presentation on. Maybe I can. Oh, maybe now.
Yes, we
Yeah,
see.
let's do this. Okay, perfect.
Mhm.
All right, so I'll go. So basically, I'm going to review a few things again. So PRP really helps us get platelets in a small amount of blood volume, like 4 to 5 ml. The beauty of PRP is that it's been used in other branches like orthopedics and plastics for a few years, and we kind of learned from them that, okay, nothing really bad is published in their data and their patient profile. Hopefully, we can use it in our patient population. And so to review again, PRP really stimulates the growth factors, that those are the factors that are in the ovary, and it kind of helps heal some of the inflammation that we think a lot of infertility may be due to inflammation, and actually kind of help regenerate the tissue around those follicles. So I kind of wanted to just go basically into the anatomy of the ovary. This is an ovary where a follicle that starts to grow and ovulate takes about 90 days. So in a woman ovulates, this follicle actually grew 90 days earlier. Having known this fact kind of helps us improve whatever, being it health-wise, acupuncture, PRP. We try to do all the maneuvers that we can, so that way when we get the follicles out, it will be in the best shape. And so I wanted to kind of review a little bit about entomolern hormone. Entomolern hormone is a hormone that's made by the cells that surround the egg. It's called the granulosa cell. So it helps us. It's a blood test that we use, and it kind of helps us know what the patient's ovarian reserve. How do we assess her fertility? Does she have a lot of eggs? Does she have few eggs? Of course, if she have very few eggs, that's the red light for us, and we kind of try to do whatever we can to help her conceive. The reality is, as women have less eggs, it makes it harder for us to find that perfect egg that will make a human being. And that's the unfortunate thing that we face day to day. And this hormone value that we check on as soon as we see her in our first visit, we check entomolern hormone in the blood. And as you can see from this graph, the optimal age is around 25, and then every 5 years to a few years, that hormone level goes down. And unfortunately, women lose approximately 1,000 eggs each month. And so the problem that we always face is that as they lose more eggs, they also have higher risk of abnormalities in their remaining eggs. So like at age 35, the risk of Down syndrome is 1 in 350. At 40, it's 1 in 100. So we kind of face a double-edged sword. We have fewer eggs, and the eggs that are there also have more abnormalities. So it makes it that much difficult to find that perfect egg that will make a healthy child. And so when we measure AMH, it kind of helps us know how many eggs, what is her ovarian reserve at that date that we measure it. The higher that number, the less stressful it is. And so like women who have lots of eggs, like PCOS, will have higher number than 5. Women who have low ovarian reserve will see that number like being around 1 or less than 1. The higher the level of AMH, the better they respond to our fertility treatment like IVF and so forth. And it's for sure definitely easier for them to conceive. And as both Dr. Chalica Farzana said, that PRP really helps us hopefully get a few more eggs by nourishing waking up the stem cells in the ovary to try to develop that egg so it could be released. And then by nourishing the environment around the egg, by growing the follicles, we hopefully get that early stage follicle was going to be released to release a little bit earlier and more mature. And the unfortunate thing is that women are, we see women now later and later at age that I see my patients. Obviously, they have careers to work on. They have other plans in their life, house, husband, and the family planning now is coming later and later. And so we're now seeing more and more patients at a later age. As we see them at a later age, they have low ovarian reserve. And those are the patients that are going to benefit from PRP. And one of the few studies showed that PRP actually can change some of the genetic expression in that ovary and allows those follicles that are dormant to wake up and be released. And also, as Dr. Trelake showed, we think that by doing PRP, we'll get better embryos. So if you get better embryo quality, you have a better chance to get the patients pregnant. And in some of our patients, we did PRP on them, and then approximately 70% of them, we saw that they got pregnant on their own, which is exciting because we're getting them ready. We're doing all the training and the ultrasounds and the blood work, and lo and behold, we do PRP, and then they're pregnant on their own. Well, it's exciting. So it's a testament to the value of this therapy. And the reality is that the younger women have lower AMHs, they have lower follicle stimulating hormone, which also increases with age. And so obviously they'll be the better ones to benefit from this treatment. We'll go back one more, sorry. One more slide. So we think that when we do PRP, we have less cancellation of our treatment with IVF. So hopefully we can get them to grow their follicles, grow their eggs, make embryos, and then have them do embryo transfer and conception. Next slide. Yeah. So there's one study I was kind of wanted to go over, just like Dr. Trelake mentioned. They took patients that have previously done in vitro fertilization and then did PRP on them. And I think some of the patients went under at least maybe 2 or 3 previous IVF cycle, and they failed. And so they decided to do PRP on them. And it's a combination of several centers. And they found that PRP decreased the chance of a woman miscarrying, which is the greatest thing that we can, because you don't want to put an embryo, get a patient pregnant, and then after all that, she ends up with a miscarriage, which is really devastating. And at the same time, they found that PRP actually doubled their chance of getting a live birth when they did IVF treatment. So that was really reassuring and exciting at the time. Next slide. So PRP stimulates the growth factor, as was mentioned before, particularly VEGF kind of increased the blood flow to the uterus. So when it increased the blood flow to the uterus, we hope that it increased the uterine lining. And it's important for us to increase your lining, because if the lining is very thin and we have great embryos, we had a hard time figuring out what are we going to do with this patient, because if we put the embryo in, the lining is thin, they're not going to get pregnant. So we try to find out whatever we can to improve the lining. We use, things from Viagra to acupuncture. A lot of stuff really doesn't work, but PRP is really something that now we're using that's really made a big change for us. And it's exciting because we always try to find whatever we can to improve our outcome. And one of the growth factors, it's called TGF-beta. So it increased the growth of the cells in the uterine lining, so that way we can have second layer. And immune modulation, with the nice part about this is that when you suppress the immune system, you have a better chance that embryo will actually grow and implant. And a lot of our patients who had previously failed IVF, failed implantation, the PRP will be extremely helpful, because it gives us just one more tool to move forward and to give them more hope. Next slide, please. And this slide, I kind of showed just a little bit about what a normal uterus here, and a uterus that's called Asherman syndrome. Asherman syndrome is a uterus that has scars inside. And it's very, very frustrating, because some of those patients will have previous miscarriages, and they had a lot of scraping or surgery done to the uterus, and it kind of gets scarred inside. And those are very difficult patients because once the uterus is scarred inside, you could go in with a camera, try to release the scars, but the lining still stays small and the scars recur. So it's an ongoing battle, and PRP kind of made a difference in those type of patients that we didn't have any treatment before. Next slide, please. And so we have seen that if you use the PRP at least approximately 48 hours prior to placing the embryos, you get a higher chance of getting the woman pregnant. And by altering the immune response of the patient, that embryo can actually invade inside the mom's lining and implant. And as I was saying before, the Asherman syndrome, where they have uterine scars, we use the PRP is extremely useful because even if we use it twice and then do another hysteroscopy, we have seen that it's definitely helpful. It gives us one more tool to combat these uterine pathologies, and particularly patients that have what we call chronic endometritis. So you put the camera in the uterus and it's all inflamed and it's all red, and you try to get rid of I pick at it and I get some of the inflammation out. It still can recur. We don't really know for a variety of other reasons. And so PRP in those patients are kind of nourish the lining, decrease the autoimmunity that's there, decrease the inflammation there, and hopefully have a better outcome. Next slide, please. And it's interesting enough that the platelets themselves have receptors to the hormone estrogen, and they are affected by two of the hormones that are secreted in the brain. Follicle-stimulating hormone, luteinizing hormone, are released in the brain, and they stimulate estrogen, and so it does affect the platelets that are growing. And so there's a interconnection between the hormones and platelets in PRP. And they do fluctuate through the menstrual cycle. We find that they're really high after ovulation, before the menstrual cycle starts. The PRP concentration is higher than in the first part of the cycle, right after the cycle and before ovulation. So right post ovulation in the second half, what we call the secretory phase, that's when the platelets are at the highest concentration. And not to underscore the biggest issue that we have, the platelets are affected by diet and lifestyle. And as you know, our population has changed, our diet has changed, our habits have changed. So we see many patients that have what we call higher BMI, and we struggle because we even have this morning. I had a hard time finding an ovary only because of higher BMI, and they're very difficult patients. And so one of the things that we have a wellness center here that we're trying to help them kind of lose a little bit of weight if they lost 5 to 10% of their weight before we try to start our treatment. It's very helpful. Not only do they have better response to medication, they have better IVF results, but they respond better to PRP treatment. So it's kind of everything kind of folds together, that if you can have a better, healthier lifestyle, better weight, you'll have better results and better response to the treatment that we give them. Next slide. And so as we mentioned before, and unfortunately, patients who are with higher BMI, their platelets are much decreased. And the nice part about PRP is that if you do PRP today, you can come back 2-3 months later and see the benefits. And some studies have showed that it even can last up to 6 months. So some of our patients, they start treatment and they do other things. They start the testing, do other things, and come back. And so if they start with PRP and then maybe say, well, I don't want to do IVF the next month or the following month, giving them this leeway of a few months is very, very helpful for us. And things like non-steroidal, like Advil or Motrin or blood thinners, unfortunately cannot be used around the time that we do the PRP. And also caffeine, like, I drink, like 4 cups a day of coffee. It actually it constricts the blood supply. So that way it decreases the healing effect of the PRP. Next slide. And as we talked about before, it's been used in other medical entities like orthopedics. So its safety has been pretty much established in other medical practices. And so we feel good that the risk of infection is extremely rare. And then the way we administer PRP is the same as the way I do in vitro fertilization. You know, the patient is, we draw her blood, and then the patient is asleep under very small amount of anesthesia through the intravenous fashion. And we just go through the vagina with a needle. It literally takes us 20 minutes. We inject the PRP just like we do in vitro fertilization, except instead of taking the eggs out, we inject the PRP into each ovary. And then the way we do PRP to the uterus is the same as taking a catheter and putting it right through the cervical canal inside the cavity, just like we do with what we do when we do IUI or intrauterine insemination. So those are conventional things that we do every day. And so doing the PRP is fairly safe for us because we've done it for so many years without any complications. Next slide. So I'm trying to go over some cases that we have with our patients. And the first patient here, she came to us from another clinic. She did 3 IVF cycles, and the problem for us is they come in with this much notes, and I have to go and shift to figure out what was going on, what was wrong, how come they did IVF, she didn't get pregnant, and she had 65 eggs from those cycles, but only 3 embryos out of all 65 eggs, which is extremely rare. And next slide. And so here, we did PRP on her twice in approximately 1 month. We got 7 eggs. I didn't want to get 65 eggs because then I wouldn't know what to do with 65 eggs. So we got 7 eggs out of her, and 3 out of 7 we did genetic testing. They were normal. And then I think 3 out of 7 were not normal. So we repeated the retrieval, and then we found some good embryos. And we did PRP also to the uterine cavity because I was worried that maybe it's not just her eggs, maybe it's the uterus. So I wanted to cover both places. And so we did PRP to the uterus with our protocol, and twice, 1 week apart. And then 10 days later, we transferred a single embryo in the next slide, and she conceived. And so it's a tough case because nobody really likes to take, those are very, very complicated patients, particularly when they have so many failure, not only the physical and the psychological impact. And then you have to pick up the pieces and say, okay, let's just try this one more thing, then hopefully it will work. And it did, and it's exciting. It's definitely an accomplishment. Next patient. This patient is also a very difficult patient. She's for 50-year-olds, and what happened as we have older patients, and particularly in 50, 51, and 52, and incidentally, we don't do any patients past 52, is that the blood supply and the contractility of the uterus changes with age, unfortunately. And so in this particular patient, we struggle because we're trying to put embryos in her, and she continues to have fluid in the uterus. And that's frustrating because you don't know what to do. Is this fluid coming from the tube, the cervical canal? It's frustrating. We didn't really know what to do. So she had previous cesarean section in the past. We thought, well, maybe it's the surgery that she had. And she had a donor cycle in another clinic, but she miscarried at 10 weeks. And in our clinic, go next slide. And we took a sample of her fluid and we send it off. We are working with LSU, and we've discovered that she has some protein that are associated with her tube. So we kind of figure, okay, well, maybe this fluid is coming from her tube. And so I took her to surgery. We did laparoscopy. I tied her tubes. It took me half an hour. And then we went back and did PRP to her uterus again, just to kind of make sure that we cover our bases, and then twice. And then we did an embryo transfer 10 days later, and next slide, and she did conceive. And that's like one of the most exciting patients, because not only they're hard to begin with, but they have so many failures. You try to think outside the box. What can we do to make things better? And it did work, thank God. So next slide. This case, again, she had low ovarian reserve. So you see the AMH is 1.29, and Normally in a 36-year-old, you like to see it between 2 to 4. So the higher the number, the more eggs they have. And we did IVF on her, and unfortunately the embryo just did not grow and didn't reach the blastocyst stage, day 5. Next, and so in her case, we did PRP to her ovaries, and then waited 3 months and did another IVF on her, and this time she had 2 embryos, which did develop to day 5, but unfortunately we checked them genetically and they were abnormal, so we couldn't use them. So now the husband is looking to have a urology consult, because on our point, it's kind of frustrating. What do we do next? We can get embryos, and now the embryos are abnormal. So what else can we do? And the patient's trying to think, what else can they do to improve themselves? So this is where we are with her. Next slide. In this case, this patient is 33-year-old, but her ovarian reserve is extremely low. It's 0.06. So think of it as, if normal is between 2 to 4, if you have an ovarian reserve at a young woman at 0.06, it's extremely low. And those are the toughest patients, because she also had 1 ovary, but even if you double this number, it's still not going to be very high. And in her case, next one, we did IVF. We couldn't get eggs, and then we had another IVF, had 1 embryo, and then we did PRP to both to this 1 ovary, and then now she was trying to get ready for another IVF cycle, and then she conceived on her own, which is incredible, because one of the things that we think we're doing is that when we put the needle in the ovary, we're kind of waking up some of the old cells, some of the cells that are there. It helps kind of increase the blood supply, decrease inflammation, nourish those other dormant follicles. So maybe this is what we're doing with PRP, on top of the fact that it has beneficial effect of tissue regeneration, decrease inflammation, and everything else. Next slide, please. This patient also she's 38 years old. She has what we call a borderline ovarian reserve, 1.43. Next slide. She went on IVF treatment. We had no embryos. And then we did PRP on her ovaries and repeated the IVF 6 weeks later. And we end up getting 5 normal genetically tested embryo, which is incredible. Because in many of our patients, where they have no embryos, they're less likely to succeed the next time. But it's exciting that we were able to totally make a 360 on her and have good embryos, good genetically tested embryo, and she conceived with them. Next slide. And this last case, she's 41-year-old, again, secondary fertility. She had, I think, a child with a previous husband, but many, many years ago, and her ovarian reserve is extremely low, is 0.01, so it's extremely low. And so again, this is a struggle, because not only she has very few eggs, the fact that she's 41 also is more stressful, because the eggs that are there could be also abnormal. Next slide. And then on her, we also did PRP into the ovaries 3 weeks apart, and we could only do it to 1 ovary. We couldn't get to the other ovary, and now she has an ongoing pregnancy. So basically, this is it. Again, like as we mentioned before, we don't have any standardization as to how many cells are we putting with each sample, how much volume do we use. We normally use about 5 to 6 ml. So we put like 3 to 4 cc's in each ovary. We don't put a huge volume. And so again, as Dr. Tralik was saying, I get calls from Austin and other places in trying to do PRP, but if they don't have at least a decent anti-Mullerian hormone number, or they're in their late 40s, where we have to unfortunately refuse them. And we're still working on with EmCyte, and with some of the centrifugation and the counting of the number of cells. And then we think that we could definitely optimize the PRP if we give it about 48 hours before embryo transfer. Thanks. I think this is it. So hopefully I wasn't that boring.
That's great. It's one of your PRP babies. Is that right?
Yes, that's it. It's one of our PRP baby, yes.
Awesome. Yeah, fascinating. So thank you so much, Dr. Alon.
Thank you.
Was great and very fascinating. And we talked about before, now it's the time we need to go for more characterization of the PRP components, because when in some rare case and complicated case, we saw that we got result. And even I had conversation with one of our doctor in MSK field a couple of weeks ago, and he had his own experience. They tried for pregnancy different ways, and they tried every single procedure approaches, and at the end they decided for the last shot try the PRP, and thank God now they have two babies. So yeah, when he shared that experience and story with me, it was fascinating for me, and
Yes.
he was a kind of a real testimonial for the PRP application in reproductive medicine. Thank you so much. We have a bunch of the questions from our audience. And so if you let me walk through the questions. So, we'd love to hear discussion of optimal protocol for frozen embryo transfer. Published study are poorly described and inconsistent. For example, in late follicular phase vs luteal phase, few days before transfer. So, do you have any specific comments on this?
So all our embryo transfer are programmed, yes. So we make sure that actually we look at the uterine cavity even before the month or couple months before with a hysteroscope, making sure there's the uterus is perfect. But as far as different protocols that's used, it's very difficult to try to, they call them natural cycle or medicated cycle. When you provide a set amount of hormone, in other words, what we're trying to do when all our embryos are frozen, and so when we do a frozen embryo transfer, we want to align the uterus with the embryo. So we use 2 weeks of estrogen, and we're able to monitor the lining, thickness of the lining by 2 ultrasound. We actually measure the value of estrogen that we give them orally. And so we kind of have two points to figure out, is this a good cycle? The lining is thick enough by ultrasound, or hormones are good, and then we start the progesterone. So this allows us to continue estrogen and do whatever we need to do before we start progesterone. Once we start the progesterone, we're committed.
And then, as just to complete the answer to this question, so when we do the PRP for the patients with thin lining, which I mentioned we don't have a lot, but when we have, we do it in the follicular phase. Before we start progesterone shots, we want to make sure that the lining grew enough that the patient is ready. So we'll never start any progesterone until we know patient is ready. So the PRP use for the patients with thin lining is always in follicular phase prior progesterone starts. Now, as for recurrent implantation failure, like I said, we don't have really optimized treatment. We are still learning. I would never call ourselves experts. We are still students. We are still learning, and we are only sharing with everyone what we have learned so far. So for recurrent implantation failure, we were always, at the beginning, we were always doing 2 rounds of PRP, few days between each other. And in follicular phase. Also, recently, based on our research in published literature, we will change our protocol a little bit, and the first round of PRP will be done in late follicular phase, and the second round of PRP, the second flush into the uterine cavity, will be done in luteal phase after progesterone is started, a few days before transfer. This is our new protocol that Dr. Alon and me discussed not long ago, and we will see if this will have better result. Although we have really, really great experience with recurrent implantation failure, although we would love to be 100% successful, we are not.
Yes.
So this is why we keep changing protocols to help those remaining 60% patients, because like I said, we really didn't go deeply through our statistics, only because we still don't have this gigantic group of patients, but we have some idea, right? So in case of a recurrent implantation failure, PRP use improved our implantation by around 60%, but we would like to help also remaining 40. So this is why we not long ago we discussed with Dr. Alon changing protocols, and from now on for recurrent implantation failure, first flush will be done in late follicular phase and the second in early luteal phase.
Mhm. Yeah.
Another question, Dr. Paul asked us, how many injections intrauterine are you doing? The series, multiple targets per setting, myometrium, or uterine bathing passively?
Yeah, we just use like an intrauterine catheter, like insemination catheter, and inject only one time. And what I try to do is I have a bulb in attached to the catheter, so I hold it in for at least 5 minutes, so that allows the PRP to kind of soak inside, and then I remove the catheter.
And the question, volume of the PRP sample infused into uterus?
It's approximately 4 to 5 ml. Yeah.
Okay.
And then maybe I will also make some comment to the Rowan Paul's question. So Dr. Alon said that we do it once, meaning in one cycle, but the procedure itself is repeated twice, but
Twice.
in one cycle. So it's
Yeah.
not serious. We don't do it to the uterine cavity in multiple months. It's only in the one embryo
cycle.
transfer cycle,
Yeah.
done twice.
So a question asked us what the data demonstrates in terms of multiple PRP treatment. For example, it appears that several clinics and studies recommended 2 PRP treatment before proceeding with IVF, and I wonder what is used as basis to recommend 1 or 2 cycles.
That's a good question. We basically we don't have clear data to support 1 or 2, but we do two PRPs to the ovary, 2 PRPs to the uterus, because we think 1 is better than 2. Yes, it's almost like when you have a wound, if you clean it twice, you get a better outcome, kind of helping lower inflammation, increase blood supply. That's how I think it will help us.
Another question, Dr. Salume Mascati, if I pronounce right, could you talk about the intrauterine injection? What kind of cannula do you use? How do you make sure it stays there? What are your post-procedure instructions? How many times do you repeat it?
So I use, as I was mentioning, I use a catheter. It has a bulb in the end of it, so it kind of plugs the cervical canal. I let it stay for at least a little over 5 to 10 minutes. The patient still lay down, and then I take the catheter out, and then she basically walks away.
So a question for Dr. Alon. If the literature suggests that ovarian PRP effects lasts 2 to 3 months,
Yes.
but follicle recruitment doubts back 90 days. So what is the best answer as to when to do IVF after PRP?
That's a good question. I mean, you're right. Do we not, based on we do it the month before, right? We do most of our stuff the month before, be it to the ovary or to the uterus. I think the closer you do it to the actual retrieval or transfer, I think the better, because yes, it does last for 6 months, up to 6 months, but I think the closer it is, the better.
Okay. So Dr.
And we started having positive outcomes, right, Dr. Alon, when we actually started repeating PRP month to ovarian rejuvenation month to month.
Yes, for sure.
Dr. Salome Mastati, is there any way I can learn how to enter ovarian PRP if I am not a REI doctor? I would love more info from the EmCyte team. So, okay. Now, from EmCyte team, we can support the theoretic part of that, but clinical aspect with the Dr. Alon and Dr. Trolley.
Sure, we'll be glad to kind of, actually, I was trying to make a video before this meeting, but the time just didn't go quickly enough for us, but we'll probably have a video.
We can do that, Dr. Alon. We
Sure,
can do a kind of a training video together.
Yeah, I think that'll be a good idea.
Yeah. So another question, is timing of PRP administration a consideration for both endometrial and ovarian procedures?
Yes, just like we said, we try to do it the closer to a couple months before egg retrieval, at least a month prior to embryo transfer.
So I think for this question, we already answered again, follicular or luteal phase, day of cycle. The question is which one and which one?
We do it in the follicular phase still, only
What
because
day of the cycle?
like we do it immediately after their cycle and before ovulation, because it's just it's a little bit safer for us in case the patient is pregnant. We don't know that she's pregnant. I don't really want to do any manipulation and then know that she was pregnant the next cycle. So we try to do right after the cycle and before day 14.
Plus, we had few patients who got their pregnant on their own, so we still leave them room.
Yeah.
After ovulation.
Yeah, so it doesn't hinder them to ovulate that cycle and conceive in the same cycle that we do it.
And again, Dr. Paul asked a question. Let me. Dr. Paul asked a question. I wonder if injection into the myometrium directly in multiple places with higher volume may work more predictably, or targeting the fallopian tube during HSG.
I mean, I think technically it might be difficult because when I do a hysteroscopy, I try to go underneath the lining with the catheter, but injecting into the myometrium is difficult unless you go with a needle, just like we do with IVF, and go directly to the myometrium. I still would be hesitant to do that because then I'm worried about infection and bleeding, things like that. I kind of want to stay with what I'm comfortable conventionally. But obviously, as there's no data for whether it's okay, it's better in the lining or better in the metrium or better in a myometrium. But I think it makes more sense to do it directly without going to the muscle.
And there is one question. I think it's a following question, but mentioned as a follow-up to the question for consecutive PRP treatment before IVF, I was actually referring to ovarian PRP, not endometrial PRP. What is the data on 1 versus 2 or 3 consecutive PRPs for ovary?
Dr. Trellick, I'll let you answer that.
Well, I mean, so like I said, all those questions are really excellent, and I wish we had as excellent answers as those questions are.
Yes.
Because, like we said, it's still exploratory field. We are still learning, and we are learning on our own mistakes.
Yes.
I always would love to learn on somebody's mistakes, but sometimes it's not possible. And when we started in 2018, we had no one to ask any questions because there were still only few clinics that offer PRP, and we are, to my knowledge, we are the only one in Texas. Back in 2018, there were even fewer. So obviously, when we came up with this idea, we were competition for the other clinics. So I wouldn't be able to grab the phone and ask, listen, how you are doing, because we want to take a small part of your business, right? So we were trying on our own with EmCyte, with great help of EmCyte. Now with PRP, with the ovaries, when we tried but only on 2 patients. One time in 1 month didn't work. I will be very honest with you, those our 2 patients, twin sisters, what I mentioned, they were very, very difficult patients. And even with our knowledge right now about PRP, we still would, that Dr. Alon would still qualify those patients for donor X.
Yes.
They still wouldn't be candidates for PRP, but didn't work. So you're like, we were a little bit discouraged, but I said, no, we cannot give up so quickly. Like, if we really want to move forward, we have to be brave and we have to keep trying, but how? And I remember we met at the conference, the group of physicians from Europe, and they told us that they do it back to back, month to month, in 2 months. We said, okay, let's try to do it like that. And this is how we started. And this is when we have this first case of patients who failed her IVF, had nothing frozen. And then when we did PRP and started preparing her for IVF, she got pregnant on her own. So this was our own idea, after advice from the group of physicians in Europe, to do it twice. Now, when we go to published studies, there were either 1 or 2. I have never seen 3. I believe that based on our very small observation, 2 is optimum.
Yeah, I think so. I think 3 is going to be just a little bit too hard for the patient to do, I think.
And then honestly, the patients, whenever they hear 2, they want to have a baby ASAP. Like, they want to get pregnant today, and tomorrow they want to deliver.
Yes, exactly.
And then we tell them to do 2 months of PRP and then IVF. So it's already long for them. And then when we start talking about 3 months, plus also we have to calculate to this whole equation cost.
Yeah.
Because this is another story.
And decreased ovarian reserve and the time and the stress all play a part of it.
So one question, I know in this field, probably you haven't started, or maybe I don't know, but the question is, into which anatomical location do you inject intratesticular PRP? You don't do that.
We don't.
We don't.
So I brought that information because of the studies, mostly in China. They started these types of study, and I could, if you email me, I could send a couple of the papers to you, Dr. Mascati. And one thing I wanted to add to all of the conversation we had, so mostly we suspend the PRP in the portion of the PPP after preparation after second SP. But one thing when I reviewed the different papers based on the mechanism and basic science behind the PRP mechanism of action for ovary rejuvenation, one of the growth factor works very, very importantly and actively is IGF-1.
Yes.
So recently, we started a kind of experiment and test regarding to another product we have, which is the concentrated protein. We actually run the PPP through the filter and wash out the PPP, because most of the case we discard the PPP. But in this case, we have ultrafiltration system. We pass the PPP through that filter, wash out the excess water, and concentrate the protein based on the size and some cytokines in the PPP. One of the most abundant protein in the PPP is going to be IGF, because we have IGF in our plasma more than the IGF in our PPP, in our PRP even. Two growth factor, HGF and IGF, the origin of them is going to be the liver. And most of the IGF in our body, 99% of the IGF bind to the protein, the carry protein, and the size is over 60 kilodalton, and our filtration system can collect everything bigger than 20 kilodalton. So the purpose of the IGF and the mechanism of IGF is minimizing the apoptosis in the oocytes, and also increase the biogenesis of mitochondria. So
Yes.
I was wondering if we could, instead of using PPP portion to resuspend the PRP buffy coat to make the PRP, remove all of the PPP, filter the PPP, make the concentrated protein, resuspend the buffy coat in concentrated protein, and then inject that for ovary injection instead of regular PRP, which is going to be the concentrated protein PRP. And we are using that for a degeneration event like knee osteoarthritis, and it works perfectly because of the A2M. Since the pathology in ovary is a kind of degenerative event, I think that could be helpful. I never seen if anybody used that, but it's a kind of idea we could work on it together. Yeah, thank you so much. There is no any other question. I will answer the Dr. Salume Masnati. My name is Sina, S-I-N-A, and the email is sina@emcyte.com. I will type the answer at emcyte.com. Thank you so much, Dr. Alon.
Thank you so much.
Dr. Tralik. It was one of the exciting, interesting, and fascinating webinar for me. So yeah, Dr. Jeannie, talk to Marisa for the video, but also we are gonna probably record video together regarding to the protocols and some hands-on techniques together. Thank you so much. You have a wonderful evening.
Thank you very much.
Thank you for all of our audience. We are going to have our next webinar in early September. I will announce through the LinkedIn. Please follow our LinkedIn. And so we are going to have another interesting topic soon. Thank you. You have a wonderful evening, all of you.
Thank you.
Thank you.
Bye.